Hey, what up all my tooth doctors and doctresses? Welcome to another video at the Tooth Factory. Today's topic, very famous for when it comes to the AFK and the INBDE exams, the drug-drug interactions for dental pharmacology. The content is created by Dr. Kanan Shah and presented by myself, Dr. Rishi Shah. Without much ado, let's dive into the drugs. The table of contents for today's lectures are antibiotics, analgesics, vasoconstrictor, anesthetics, and sedatives. So what is drug-drug interaction? Now consider this, what happens when drugs cross the pharmacodynamics and pharmacokinetics? Now I know we haven't covered these topics yet, but we will be taking them over in the next video, so keep an eye out. What it means is what the drug does to the body and what the body does to the drug. However, when two drugs are mixed together, then what happens to each other? And that is drug-drug interaction. So let's dive in. Topic 1, antibiotics, drug interactions. To keep everything simplified, we have created this tabular form. Throughout the entire slides, we will be discussing 51 different types of drugs today. So the table says which type of drug is being used, and then interacting drug with the primary drug, leading to the consequences of the interaction, and what is recommended clinically. So let's go on. First one, overall antibiotics, basically all of them, interacting with oral contraceptives will lead to a decreased effect of oral contraceptives, a decreased blood level of oral contraceptives. And this is all because the antibiotics will kill our gastrointestinal flora, the bacterial flora, that recycle the contraceptive steroids. So keep in mind that if the antibiotics kill the GI flora, there will be no recycling of contraceptive steroids. That leads to a decreased effect of oral contraception. There's not much to be worried about in this scenario. You could continue to use this combination of drugs. However, you must inform the patient that this may happen. And in this, a little note that rifampin is the strongest of them all. Next, beta-lactams such as penicillins and cephalosporins in antibiotics, we covered that in our antibiotics videos. When they are mixed with allopurinol, which is an anti-gout medication, it can lead to minor allergies, especially with ampicillin, which is one of the penicillins. Therefore, we must avoid the combination of penicillin, cephalosporins, along with allopurinol. So I'm hoping everyone's getting the concept of how today's lecture is going to be attributed so that we can pick up the pace a little bit, and it'll give you guys some time to study as well. The third drug for the day is also beta-lactams, penicillin, cephalosporins, mixed with beta blockers, especially atenolol. This will lead to a decreased blood level of beta blockers due to the ampicillin overuse. Again, ampicillin is a culprit. It will lead to decreased blood levels of beta blockers. Anaphylactic reactions to the penicillins are more severe. This is for the people that are allergic to penicillin, type 1 reaction. Then there's increased mast cell mediators. Again, that's also associated with the anaphylactic reaction. In this, we're going to be cautious with ampicillin. Now, in this first slide, we went a little slow. Just to kind of get used to the concept, we realize that the green is for continuing to use, the red is to avoid, and the yellow is for caution. So that's how we'll follow through with the rest of the drugs. Let's move on to the next one. Penicillin cephalosporins, when mixed with tetracycline, will lead to a static-cidal reaction, leading to a decreased effects of penicillin and cephalosporins. Now, what does that mean? In pharmacokinetics and pharmacodynamics, there is a concept of static-cidal reaction. We know that tetracyclines, from our antibiotics video, we know that it is a static, and we know that penicillins and cephalosporins are cidal drugs. When both of them are mixed together, they counter each other, which means there will be a decreased effects of the penicillin and cephalosporins. Therefore, we avoid the combination of the two antibiotics. Tetracycline and fluoroquinolones mixed with antacids, like the TUMS, basically calcium carbonates. They will lead to a divalent trivalent chelation, especially with the calcium ions. We've always heard this before, right? That tetracyclines shall not be used with calcium ions. Decreased absorption of tetracycline leads to not enough action being produced. So tetracycline will leave our body without being absorbed. And then doxycycline is safer with calcium ions if we have to use tetracyclines. Either way, we still should avoid the combination. This is tetracycline fluoroquinolone with antacids. Next one is tetracycline fluoroquinolones with insulin. Insulin is a hypoglycemic drug that can lead to increased hypoglycemic effects of insulin. So remember that tetracycline fluoroquinolone is mixed with insulin, especially doxycycline and oxytetracycline, will lead to increased hypoglycemic effects of insulin. Therefore, we must be cautious. Increase carbohydrate intake and consider a different antibiotics when mixed with insulin. I hope everyone's following. And the next drug is doxycycline with methotrexate. Methotrexate is ideally used for rheumatoid arthritis as an immunosuppressant, and it leads to methotrexate toxicity, especially with high dose, and especially with doxycycline we mentioned. Therefore, we must be cautious. We could use a different antibiotic. Next is metronidazole. I know this is one of those very heavy, the gram-negative bacteria-killing drugs, but when you mix it with ethanol, especially alcohol, you get severe disulfiram-like reactions, which is an alcohol withdrawal symptom, right? When you mix a drug that's highly active with liver, mixed with alcohol, also affecting the liver, you get alcohol withdrawal symptoms. This is a combination that we must avoid. Next one is metronidazole with lithium. Lithium is a very, very popular drug for bipolar treatment. It's a drug of choice. When you mix it with metronidazole, you have decreased renal excretion of lithium, increased blood levels of lithium, right? They're correlated. If there's less excretion, there's increase in blood levels. Then lithium toxicity leads to confusion, ataxia, and kidney damage as consequences of the interaction. Therefore, we avoid the combination. Next page, we have CYP3A4 or CYP12A metabolized macrolides and azoles. Now, azoles are antifungals. I know they're not antibiotics, but they fall under the same group. Now, oh my God, so what is this, right? We have various different types of enzymes in the liver. They're known as, say, cytochrome P3A4, cytochrome P12A. For example, these enzymes are responsible for metabolizing macrolides and azoles, right? So when these are metabolized, and you're adding another drug that affects the same enzyme, we will have interactions and consequences. So when macrolides such as erythromycin and clarithromycin and azoles such as ketoconazole and fluconazole is mixed with benzodiazepines, which are anti-anxiety drugs, it results in a delayed metabolism of benzodiazepines. What does that mean? Well, there's increased effects of benzodiazepine because we're not breaking the benzodiazepines down. We're keeping them in our body. That will lead to extensive sedation and irritation. Therefore, we avoid this combination at all costs, and we would have to reduce the dose of benzodiazepines if we must use them. Now, this category of the drugs with the liver enzymes will be a lot. So whenever we mix all of these with different types of drugs, we will have a very common pattern. So we'll notice that in just a second. Another antidepressive drug is buspirone. So the same category of drugs mixed with buspirone will lead to delayed metabolism of buspirone and increased effects of it. This is the same as benzodiazepine, right? Delayed metabolism and increased effects. Therefore, we avoid the combination. So same category again, mixed with calcium channel blockers, which we know are to be antihypertensive drugs from our video on antihypertension, will lead to delayed metabolism of the calcium channel blockers and increased effects of the calcium channel blockers. Now, calcium channel blockers are antihypertensive. If you have increased effects of antihypertensive drugs, will lead to hypotension, specifically with macrolides. So we avoid the combination. Perfect. Moving on to the next one. Same category, macrolides and azoles, mixed with carbamazepine. Carbamazepine we've known for anti-epileptic properties and in the treatment of trigeminal neuralgia. So when we mix those categories with carbamazepine, we will get increased blood levels of carbamazepine toxicity, just like the other categories on the previous page, increased effects of carbamazepine. It will lead to drowsiness, dizziness, nausea, headaches, blurred vision, and it could cause hospitalization at the end. Therefore, let's avoid that combination. Drug number 14, same category with the GERD treatment, which is cisapride. We will have delayed metabolism of cisapride, leading to arrhythmia, and there's a death risk. Now, I know this is not much of a common drug, but it was in the category when we went through the resources in Malamed and Little and Falace. Drug number 15. We have macrolides azoles mixed with cyclosporin organ transplant drug. It's an immunosuppressant, right? So it will lead to increased immunosuppression, increased nephrotoxicity because it's not leaving the body. So we avoid the combination. So think of it this way. Every drug that has been in combination with macrolides and azoles, which are metabolized by the cytochrome P3A4 and cytochrome 12A, they will lead to increased effects and decreased metabolism. So let's keep that pattern in mind. Drug number 16, same category, mixed with antiarrhythmic class 1 drugs, especially quinidine, very important, and of course the disopyramide. This will lead to the inhibition of CYP3A4. When this enzyme is inhibited, we will not be able to metabolize the antiarrhythmic drugs. Therefore, there will be increased effects of antiarrhythmic drugs. Therefore, causes arrhythmia instead. So let's avoid this combination. So I just want to draw this little diagram to help you understand what is this inhibition and so on. So think of it this way, that when liver enzymes are inhibited, so inhibited and activated. Sorry, terrible writing, guys. But when they're inhibited, the drug's effects will increase because there is less metabolism. And when these enzymes are activated, the CYP enzymes, then the effects of the drugs are decreased because high activity of those enzymes will lead to high metabolism. So this right here, when we're looking at the inhibition of the enzyme, we're leading to increased effects. So remember that pattern. Whenever liver enzymes such as CYP3A4 is inhibited, we will not be able to metabolize the interacting drugs. That leads to increased effects of the antiarrhythmic drug because of decreased metabolism. I know there's a lot of back and forth of increase and decrease, but I hope it helps clarify a few doubts in that section there. Okay, moving on. Drug number 17, same category, mixed with the statins, which are antilipids. Again, they will have increased blood levels of statins because we have inhibited the liver enzymes. This leads to myalgia, eosinophilia, that's what it's called. Specifically, it's a muscle breakdown, which is known as rhabdomyolysis. Remember, lysis is the breakdown of muscles or breakdown of anything associated with the word lysis. So, rhabdomyolysis. And acute renal failure, again, because there's high levels in the blood, it's not clearing the body, leads to acute renal failure. So let's avoid the combination. Drug 18, same category with pymazide, which is an antipsychotic. Again, increased concentration of pymazide leading to prolongation of QT interval. This is just a cardiac manifestation of this combination, so we must avoid this. Next category. CYP3A4, CYP12A metabolized macrolides and azoles mixed with our prednisone, corticosteroids. Guess what this does? Same thing. It increases the risk of Cushing's syndrome and increases the immunosuppression activity, leading to us avoiding the combination. Drug 20, I know we're still on the same category, but that's great because majority of it is easy to remember, right? When it's mixed with theophylline, which is a phosphodiesterase inhibitor, it's frequently used in asthma, and you could also use it in the phosphodiesterase inhibitors in congestive heart failure as well. When that happens, this is something unique. See, erythromycin is the main problem in this. We know that erythromycin is a macrolide. It will lead to the inhibition of theophylline metabolism, just like any other drug, which means there's increased blood levels of theophylline. Perfect. But on the other hand, there's a decreased blood level of erythromycin. See, theophylline likes to hammer back on erythromycin. Therefore, we definitely should avoid the combination. Moving on. Now we're into different groups of drugs, but in different combinations. So if erythromycin, clarithromycin, or tetracycline here is mixed with digoxin, which is a drug used in congestive heart failure. A fun fact about digoxin, it is used to increase the stroke effects in the heart, not the conduction. So remember this little term, just as a fun fact, that digoxin increases the contractility of the heart, not the conduction rate of the heart. Okay, so moving on. Erythromycin, clarithromycin, or tetracycline. When they're mixed with digoxin, we have altered GI flora. So these drugs, antibiotics, will alter the GI flora. So what? Well, therefore, it decreases the metabolism of digoxin. Digoxin toxicity takes place, and for a duration of weeks, not just immediate. It leads to salivation, visual disturbances, and arrhythmia. And another fun fact about digoxin, in any question such as associated with digoxin in the AFK and INBDE, you see yellow halo. Yellow halo is a visual disturbance of digoxin. So remember yellow halo. Okay, so in this term, it's generally safe in 90% of the patient, this interaction, but we should still be cautious of it. We should monitor the combination. And of course, let the patients know. Very important. Drug number 22, when erythromycin, clarithromycin, or cephalosporins, or metronidazole, we've already talked about these drugs in the past in our videos in antibiotics as well. When they're mixed with warfarin, warfarin is a drug that is basically an anticoagulant. It is used in the treatment of myocardial infarction or stroke prevention. We have a decreased bacterial load, which produces vitamin K. Okay, so what? Well, it increases the relative effects of warfarin. Now, why is that? So let's take a look at it. I want to, again, I'll draw a little something for you guys here so we understand. See, in our gut, we have, in the gut, we have vitamin K producing bacteria, right? So vitamin K producing bacteria. Now, if those bacteria are dead, then we will have less of vitamin K being produced, right? Less vitamin K. So far, so good. If we kill the bacteria that produce vitamin K, it will produce less vitamin K. Perfect. So that's set. Now, how is that associated with warfarin? Now, warfarin we know is an anticoagulant. Anticoagulant. And fun fact, vitamin K is a coagulant. It's a coagulant. Now, here's the catch. I'm going to erase this and we'll go at it again. So if increase in vitamin K is coagulant and increase in warfarin is anticoagulant, and if we reduce the vitamin K by killing the bacterial load here that produce vitamin K, we will get rid of the coagulant effect, correct? That will lead to relative increase of the warfarin's effect as anticoagulant. Therefore, there is increased chance of bleeding. So far, so good? So in essence, what we're saying here is that vitamin K is inversely proportional to warfarin. Basically, if one increases, other decreases. Perfect? Awesome. So let's move on from this concept. Very important concept for the exams, by the way. And just a little fun fact as well, that antibiotics themselves have a very minor anticoagulant effect. Therefore, in this case, we will be cautious and monitor INR. INR is known as International Normalized Ratio. In our further videos of medical management, we will talk more about INR, but it is a measure used to keep track of warfarin's activity. INR, remember that. Other options are to choose penicillins, tetracyclines, and clindamycins. And that was antibiotics. Look at that, how quick, right? So let's move on to analgesics, our next topic. Analgesics, so our title here has changed, but all the other categories are the same. Okay, drug number 23, remember we're going to 51. Acetaminophen mixed with alcohol can be a combination of concern, especially with alcohol abusers. So alcoholics, basically. It can be given with non-alcoholics, with a no disease person, but there's still increased risk of liver toxicity when you take more than 4 grams per day of acetaminophen. So this is our maximum daily recommended dose, right? Maximum. You can't cross the 4 grams, 4,000 milligrams we cannot cross. If we cross more than that in acetaminophen and are consuming alcohol, then we avoid the combination. Next is acetaminophen with warfarin anticoagulant. It increases the risk of bleeding with more than 2 grams of acetaminophen per day for more than 1 week. Again, why are they related? Solely because of liver function exchange, right? They're both functioning at the liver. Remember, acetaminophen and alcohol, both liver. Very common patterns in there. So let's be cautious and monitor the INR. Remember, warfarin linked with INR. Lots of patterns here, guys. Feel free to go back and forth and write yourself your own notes. Remember that we could use low dose acetaminophen and duration to avoid risk of bleeding. Okay, drug 25, aspirin, also analgesic, also known as ASA, acetyl salicylic acid, when mixed with oral hypoglycemics such as sulfonylureas, glyburide, chlorpromide. All of these will lead to displacement of sulfonylureas from protein albumin binding. Hence, it increased active hypoglycemics in the blood, leading to increased hypoglycemia, and we avoid the combination. Now, what does all of that mean? So, I'll explain that in just a second here. Go back for a second. So it says displacement of sulfonylureas from proteins, right? Such as albumin binding. So keep that in mind. That's point number one. Hence, it increases active hypoglycemics in the blood, leading to hypoglycemia. So 3 steps. So let's draw the 3 steps so we understand better. Step 1. We know that the oral hypoglycemics lead to decrease in blood glucose levels, correct? We know that. Second, it is important that we know that all drugs in blood go through what is called as protein binding. And that protein that we talk about is albumin. Albumin likes to hold on to the drugs. Now, the important point is step 3, that if albumin holds on to the drug, then the drug is inactive drug. So remember that. So every time albumin holds on to the drug is inactive. Therefore, if albumin lets go of the drug, they become active. Correct? So far so good? Okay, perfect. Now, the pattern with aspirin is that if there is a oral hypoglycemic attached to albumin, oral hypoglycemics will come in, attack that bond, and break it. Okay? So now in that case, what happens is oral hypoglycemics will leave and albumins will break off from them. Therefore, now oral hypoglycemics are active. Remember, this was not intentional. This is when ASA, aspirin, came in and broke this bond, leading to excessively active oral hypoglycemics. Therefore, increased in hypoglycemia. Low blood sugar levels. Okay, I hope that concept is clear. So let's move on to the next drug. Drug number 26, aspirin and other NSAIDs, mixed with anticoagulants such as warfarin. Here it is again. This will definitely lead to increased risk of bleeding. We know that for sure. GI and oral ulcerations are spontaneous, so we avoid this combination, especially in alcoholism. Now, why is this? So just to explain the concept, ASA plus warfarin, right? So ASA, its job is to block COX, right? COX, COX, 1 and 2. Warfarin's job is to increase bleeding. Okay, so far so good. So what does COX have to do with bleeding? Remember that COX have to do with prostaglandin E2, this little person of ours in our blood systems is responsible for maintaining integrity of tissue and blood vessels. So let's say if aspirin blocks COX, therefore it blocks prostaglandin E2, that leads to no integrity of blood vessels, leading to increased bleeding. Increased bleeding how? Well, ulcerations, because the integrity of the tissue and blood vessels is lost. So ulcerations will lead to bleeding, especially spontaneous. I hope that's very clear. Okay, so we avoid that combination. Next drug. Aspirin and NSAIDs mixed with alcohol abuse, increased risk of bleeding. GI and oral ulceration, same thing. Avoid combination. We stop the alcohol and lower the aspirin dose. This is because of liver function exchange. Aspirin mixed with diltiazem, which is a calcium channel blocker, will have increased antiplatelet activity of aspirin and prolonged bleeding at risk. This is not avoiding, but we should be cautious and monitor bleeding and bruising. So again, aspirin's antiplatelet activity is increased, leading to prolonged bleeding. That's calcium channel with aspirin. All right. Next one, drug 29, NSAIDs overall, generally all of them, when they're mixed with beta blockers or alpha blockers or ACE inhibitors, angiotensin converting enzyme inhibitors, we will have a decreased antihypertensive effect, causing hypertension to occur. Okay, so let's take a look at this concept. See, we know that all the NSAIDs block COX, therefore it blocks prostaglandin E2. Now when this is blocked in kidneys, it results in less function of kidneys, correct? Therefore, if kidneys have low function, it leads to decreased excretion, therefore increase sodium, water retention. So coming back to the basic principle, if sodium water is retained in the body, it will lead to hypertension. Simple? Awesome, guys. You guys are doing great. I know it's a little dry, but I'm trying to make it very interactive so that everyone gets interested. So in this case, we will have caution and decrease the NSAID duration to 4 days only and use acetaminophen. This guideline is very important. I have seen these questions on INBDE and AFK both. Now, NSAIDs mixed with lithium, which is a bipolar treatment drug, it will be increasing the blood levels of lithium, causing lithium toxicity. Decreased metabolism of lithium is the mechanism of the interaction. We avoid this combination. NSAIDs, especially naproxen. Naproxen mixed with alendronate, which is a bisphosphonate, will lead to increased risk of gastric ulceration. Same problem. Alendronate bisphosphonates will suppress our own system to help us recover. I apologize. It will prevent us from recovering of our injuries. And NSAIDs will add to that because it will block prostaglandin. Now, a fun fact about naproxen. When there is cardiovascular issues like this up here, antihypertensives, naproxen is actually a safe NSAID to use. So just a little side point there. And we avoid this combination with naproxen and alendronate. We use acetaminophen instead. Okay. Next one. NSAID overall with methotrexate. I know we've seen this before. Just like lithium, it's just a repetition, right? Toxicity of methotrexate increases immunosuppression. Therefore, we should be cautious and decrease the dose of methotrexate. NSAIDs plus selective serotonin reuptake inhibition, such as citalopram, sertraline, so on, they cause increased risk of peptic ulcers. Remember, NSAIDs are highly associated with peptic ulcers, therefore we avoid combination for long duration of NSAIDs and SSRIs. Next is meperidine. Meperidine is our opioid, very naughty drug, mixed with MAO inhibitors, monoamine oxidase inhibitor, will lead to severe fatal adverse excitatory and depressive reaction. CNS stimulation caused by normeperidine enhances the MAO inhibitor action. Therefore, we avoid the combination. Wow, what does that mean? So to understand that, we need to first understand what MAO inhibitor does. See, MAO is responsible for reuptaking the norepinephrine from the synaptic cleft. And meperidine, which is a very naughty drug we mentioned, that it's got a normeperidine metabolite, that is a CNS stimulant. They both will act together. How? Let me show you in a little drawing here. So, sorry about that. We have synaptic cleft, right? Here we have various norepinephrine as our neurotransmitter, right? Going from one direction to the other. Well, here, there is a little enzyme, or a catalyst, I must say, known as MAO, monoamine oxidase inhibitors. They will go to the excess norepinephrine and pull them back up, correct? So therefore, MAO will lead to a decrease in norepinephrine. Therefore, if decrease in norepinephrine leads to decrease in stimulation. Okay, now what if we have a MAO inhibitor? Therefore, norepinephrine will now increase. Therefore, increase in epinephrine, leading to increase in stimulation. So we now know that MAO inhibitors will increase CNS stimulation. Now what's the story on meperidine? And how does it link here? Okay, so meperidine has a metabolite, which means when it gets metabolized in the liver, it leads to a side little feature formed known as the naughty normeperidine. I keep saying naughty because it helps remember the normeperidine. See, meperidine ideally is a CNS depressant, right? It's an opioid, but its metabolite, normeperidine, is a CNS stimulant. Yep, that's the twist of the plot. Very, very important. Meperidine is risky with MAO inhibitors because this is a CNS stimulant and MAO inhibitor is also a CNS stimulant. So I hope that's very clear there. So let's erase our little whiteboard here and go back and read it one more time. Meperidine, MAO inhibitors. When they're mixed together, we have excitatory and depressive reaction at the same time, very fatal. CNS stimulation is caused by normeperidine enhancing the MAO inhibitor action. So we avoid the combination. I hope that's very, very useful to understand, guys. Just trying to make it as simple and fun as possible. We're almost there. Drug 35, propoxyphene. Another opioid mixed with carbamazepine will lead to increased plasma concentrations of carbamazepine, excessive blockade of sodium channels. Remember, propoxyphene is a CNS depressant. Carbamazepine, also the same, leading to excessive blockade of sodium channels. Avoid combination. Next. Oh, look at that. We're at the end of analgesics. Next is vasoconstrictors. Vasoconstrictors, the two that we talk about in dentistry is epinephrine and levonorepinephrine. Those are the two vasoconstrictors we talk about. When they are mixed with non-selective beta blockers, which means when they block beta 1 and beta 2 at the same time, those are nadolol and timolol. So this is something that I want to add here for this. How do you remember non-selective beta blocker and selective beta blocker? Very simple trick. We have non-selective, anything after N to Z. So nadolol, timolol, right? Selective are A to M. So, for example, atenolol and metoprolol, these guys are selective beta blockers. Just a little side note for fun. Okay, so moving on. Non-selective beta blockers, nadolol, timolol, mixed with epinephrine will have unopposed effects. See, it'll lead to increased blood pressure due to increased alpha-1 by the epinephrine and levonorepinephrine and blockade of beta receptors leading to secondary bradycardia. So think of it this way. We have a video on adrenergic receptors that you can check out to understand better the adrenergic system. But look at this, that if epinephrine acts on alpha-1 and it increases its activity, it will lead to increase in blood pressure. So far so good? Okay. Now if beta is blocked, therefore if heart is blocked, we will have decrease in heart rate. Right? The heart actually itself has little to do with the blood pressure change rather than the beat of the heart, right? The vessels from alpha-1, which is a vessels, peripheral vessels, the PVR, right? Peripheral vascular resistance. That's more important on the blood pressure. So think of it this way. There is increase in the blood pressure and bradycardia from beta blockers. This is unopposed effects. Okay. Therefore, the guidelines for this combination in clinics is we must be cautious. The first dose should be a half cartridge at 1 to 100,000 epinephrine. Aspirate to avoid IV injection. Inject slower than usual. If all is normal, then inject up to 2 cartridges with 5-minute intervals and avoid retraction cords with epinephrine. Avoid these because retraction cords with epinephrine have a very high concentration, even more than 1 to 100,000. Specifically speaking, it has a 1 to 1,000. That's a very, very, very high concentration. That means it's highly likely that epinephrine's effects will be increased, leading to hypertension. That's why we must avoid it. Okay, guys. Next one. Epinephrine, levonorepinephrine mixed with cocaine. Now, fun fact about cocaine: it is the only LA with a vasoconstrictive property. All the other LAs are vasodilators, except cocaine. So, a vasoconstricting LA mixed with epinephrine, which is a generic vasoconstrictor. This will have a blockage of reuptake of norepinephrine. That's the role of cocaine. When norepinephrine is not reuptaken, it will increase postsynaptic effects of epinephrine. That's as simple as it gets. Increased adrenergic effects of the heart, leading to a risk of heart attack. So we avoid vasoconstrictors with cocaine abusers is completely avoiding. And we must withhold the cocaine for 24 hours, also because it's very, very risky for other effects as well. So next one. Epinephrine, levonorepinephrine with halothane. Halothane is not used in dentistry as much as we'd like to understand, but just as a drug interactions understanding, when epinephrine is mixed with halothane, it leads to alpha-beta stimulation, leading to arrhythmias, especially with more than 2 grams per kilogram. Avoid retraction cords with epinephrine. Limit the halothane to 2 micrograms per kilogram. So we're just kind of understanding that both of them are stimulating the heart and vessels. Epinephrine, levonorepinephrine with tricyclic antidepressants, TCAs. Now, TCAs are great because they're antidepressants by blocking the reuptake of norepinephrine. So it has nothing to do with norepinephrine reuptake. So it increases the norepinephrine in the synaptic cleft, leading to increased pressure response, increase in blood pressure, with increase in heart rate and cardiac arrhythmia at risk. Remember, epinephrine is directly on the vessels. Tricyclic antidepressants will also increase norepinephrine activity, leading to increased blood pressure. So avoid levonorepinephrine for sure, 100%. But with epinephrine, you could limit the dose to 0.04 milligrams. Avoid retraction cords with epinephrine as always. Next is epinephrine with MAO inhibitors. We went through this already, that it blocks the reuptake of norepinephrine, just like TCAs, increases blood pressure, leading to increase in heart rate, leading to cardiac arrhythmias. Both of them will increase cardiac activity. So avoid levonorepinephrine, limit the epinephrine dose to 0.04 milligrams. Avoid retraction cords as always with epinephrine. Next, with antipsychotics, chlorpromazine and clozapine. Epinephrine mixed with antipsychotics will lead to a decrease in blood pressure, causing hypotension. Now this is opposite, almost psychotic, right? Think of it that way. That normally epinephrine mixed with any other drug led to increase in heart activity, such as increasing blood pressure. But when it's mixed with antipsychotics, it went a little psychotic, and it now decreases the blood pressure, causing hypotension. So again, avoid the retraction cords and limit the epinephrine dose. Epinephrine with the peripheral adrenergic antagonists, such as reserpine and guanethidine. Now, reserpine and guanethidine mixed with epinephrine leads to increased sensitivity of adrenergic receptors to epinephrine. Interacting drugs prevent the release of norepinephrine into synapse. What does that mean? Well, the role of these two drugs is to prevent the release of norepinephrine. That's the function of them. Therefore, all receptors at postsynaptic area are open, as there is no epinephrine, no norepinephrine available. Therefore, external epinephrine will stimulate all of these open receptors. leading to adrenergic receptors increased sensitivity. Perfect. And again, same rules apply. We avoid the combination especially with the retraction cords of epinephrine, and limit the epinephrine dose to 0.04 when injecting it. Next is COMT inhibitors. Now, COMT is catechol-O-methyl transferase inhibitors. They prevent the breakdown of epinephrine. So in the synapses itself, COMT is another enzyme that not reuptakes, but actually breaks down excess norepinephrine. If that COMT is inhibited, it will lead to prevention of breakdown of epinephrine, leading to increased blood pressure and heart rate. This will lead to arrhythmias. So they both will up the heart activity. We avoid retraction cords with epinephrine and limit dose of epinephrine to 0.04. Okay, I know we've talked about a lot. We've covered almost more than half of it, so let's move on to the next topic. We have anesthetics and sedatives left, the shortest of the lot. Anesthetics. Lidocaine with bupivacaine will lead to CNS toxicity caused by increase in doses of both. Therefore, let's just be cautious and reduce the doses of each. Lidocaine with tramadol. Tramadol is one of the opioids. When they're mixed with lidocaine, it may cause seizures in elderly and alcoholics. So let's avoid the combination. Limit the dose if must be used together. Mepivacaine, another local anesthetic, mixed with meperidine, which is a naughty opioid. Remember that. Will lead to opioid sedation with anesthetic, leading to toxicity, especially in children. It's a very, very heavy toxic effect in children. The caution and reduce the dose of mepivacaine when used with meperidine. Remember, out of all these three vasoconstrictor, we're only avoiding lidocaine with tramadol. Okay? Next. We're now on to the sedatives right here. Sedatives such as barbiturates. Now, these are very angry drugs, okay? So barbiturates, when mixed with digoxin or theophylline, corticosteroids, and warfarin, this family right here, it will lead to barbs binding to cytochrome P450 in the liver. Again, remember the CYP enzymes? This is a 450 in the liver. The barbiturates will bind to CYP450 in the liver, will increase the metabolism of many drugs. So unlike the others that we talked about earlier, barbiturates will actually enhance the metabolism, leading to decreased effects of anticoagulants. Perfect. Remember, when we increase metabolism, we decrease the activity. Correct? So we avoid the combination generally, limit the doses if we must use them together. Barbiturates, again, mixed with benzodiazepine, alcohol, and antihistamines, will have additive effects for sedation and respiratory depression. Now, these are both respiratory depressors. If we use them together, it will have additive effect. Therefore, let's just be cautious and reduce dose while monitoring side effects. Benzodiazepines, mixed with protease inhibitors. This is anti-HIV, specifically, say, indinavir in this category, mixed with benzodiazepines, will increase the bioavailability and effects of benzodiazepine, especially triazolam and oral midazolam. Can we guess why there's an increase in bioavailability? Well, because there's decreased metabolism. So we'll always try and link those two terms, right? Metabolism and effects. If there is decreased metabolism, there's increased effects. Perfect. So we avoid this combination of benzodiazepine and protease inhibitors. Next. Benzodiazepines with this group of drugs, which is cimetidine, oral contraceptives, fluoxetine, which is an SSRI. We've talked about that today. Isoniazid, the TB drug, alcohol, and the azoles, the antifungals. When all of these drugs mixed with benzodiazepines, we have delayed metabolism of benzo. So let's guess what that is. When there's delayed metabolism, there's increased effects of benzodiazepine. Perfect. Great job, guys. It increased the excessive sedation effect of benzodiazepine, leading to us avoiding the combination or reducing the dose of benzodiazepines. And we mentioned that there's 51 drugs. Here's the last one. Thank you for staying with us. Benzodiazepines mixed with digoxin, phenytoin, and theophylline leads to toxicity of digoxin and phenytoin. Why? Because there's decreased metabolism. It also blocks the effects of benzos. Remember, theophylline is that one that hammers back, right? So it blocks the effects of benzodiazepine as well, leading to us avoiding the combination. That's the end of sedatives. Our resources for the lectures are these two textbooks. We have Little and Falace, and Malamed. I have placed the links in the description box below for both of these textbooks so you guys can go inside and read. Hopefully our charts helped you guys. So remember, in the whiteboard, we're going to talk about two major things. First of all, the relationship of metabolism versus effects. So if this is increased, this will be decreased. If metabolism will be decreased, the effects will be increased. Remember that for any drug interaction, to remember patterns. That's the first thing. The second thing we need to remember in drug-drug interaction is when liver is involved, we have CYP enzymes that play a role, such as 450, such as 3A4, such as 12A, right? We've already looked at that. Whenever these are inhibited, we have decreased metabolism, leading to increased toxicity. Whenever these are activated, we have increased metabolism, leading to decreased toxicity. This pattern, if you can remember this pattern right here in drugs that are involved with liver enzymes, majority of our drug interactions are set. And the last thing that I want to point out here is pharmacodynamics and pharmacokinetics are the #1 mechanisms of drug-drug interactions. So, just trying to introduce our next video here, is pharmacodynamics is what the drug does to the body, and the kinetic is what the body does to the drug. So we'll be talking about that in our next video to help us understand all of these concepts better. Okay? I really hope you guys learned something new today, and hope these lectures and these notes, which are also available in the description box below, help you guys. Please stay tuned with the Tooth Factory for more, and please do like, share, and subscribe to help us, and our motive to help all these dentists around the world learn more and crack these exams well, especially learn during their BDS or DDS around the globe. We are always here. TTF is always here. So thank you so much for staying tuned with us. See you again.